Thank you, Chris. Appreciate everyone being here today. I think we have a very exciting panel on the buyers of healthcare, and that's really been the strong emphasis on the FMMA conference for this year. I'm going to do introductions, and then I think each one will tell you all where they are in their free market journey. And some are at varying different levels. Some have moved very quickly, and some are going through different pain points. But that's what we want, to is kind of have an honest conversation of how the buyers have succeeded and what they're looking to do in the future. And then we'll have audience questions right at the end of this. So immediately to my left is Drew Jacobs, who's president of Adfitech, a mortgage services provider in Edmond, Oklahoma. Rumor has it this bandage on Drew's hand is actually Drew experimenting with free market healthcare very recently here. Taylor Pitlik of Pitlik and Wick, a construction and engineering company in northern Wisconsin. And Steve Boyd, I know many of you know Steve Boyd from Southern Scripts, PBM. Steve's also a free market employer, and he's here to talk about that. And Derek Francis, the CFO of Hospice of Wichita Falls, who most recently of the group, I think, began your free market healthcare journey late last year. So with that, we'll start with you, Drew, and kind of take us through your journey.
So Todd, it is not a rumor. I have enjoyed this conference thoroughly the last couple of days, and I've heard all these people talk about the FMMA and the opportunities, but it's all been talk, right? Not much been seen. So I'm kind of a doer. So 2 weeks ago, I went to SCO to prove how great they are. And it was a great opportunity. I followed the bouncing ball, and I can tell you on my plan, this cost me $0 because I followed the bouncing ball. So what is that bouncing ball? I met Jay Kempton in 2015-ish. He spoke at a chamber conference, introduced the concept of self-funding. It's tough times in the mortgage industry. We were trying to control cost, trying to figure out where those costs could be tweaked away. Health insurance is 2 or 3 on my P&L as far as the cost. Kind of got my attention. But changes are hard until there's a necessity for change. So sometimes that necessity is something breaks. Well, I had a personal experience. I apologize. Some of you have heard this story. I was out to dinner with my board of directors. And during that dinner, I choked on a piece of meat. Didn't choke, it got lodged. So I had the opportunity to visit the hospital. A couple days later, I had the opportunity to get a tube thrown down my throat, expanded my esophagus, and was told I had GERD. The doctor at the time, on an Aetna plan, am I allowed to say that? On some insurance plan, gave me a medicine to control GERD. A nickel a piece. Seemed like that was a good deal, except I didn't like it. It didn't make me feel good. So she said, no problem, we have another option. She gave me a little bottle, walked out of her office, tried it. Made me feel a little bit better. Okay, I guess second try, I'm stuck with it, I'm gonna use it. The sample ran out, went to the pharmacy to get it filled. Well, when they give away samples, it's probably not gonna be a nickel a pill. $1,800 a month for this GERD medicine. It's like, that just does not sound right. At that moment, I decided to follow up with Jay Kempton and figure out what this DPC market was all about. Because from the research I'd done, the DPC is a start and the foundation of a self-funded health plan. Why do I say that? Because I can't see you guys, but I know there's a few of you out there. The DPCs understand the FMMA, free medical market, better than anybody. They've quit the big time hospitals to be part of this movement. They've made a change of life. So I picked a DPC that I knew of, that Jay Kempton knew of, and I went to him with this GERD problem. Nickel a pill, $1,800. He laughed at me as I told him the story. He said, there's 20 different pills that we can try that are generic before we even have to think about going to that one. At that moment, I figured out that's the way to go. find the right providers that are willing to spend the time with you, and FMMA will work. Self-funded plans will work. So, worked really well for me. Taught me how to follow the bouncing ball, and Dr. Rogers talked yesterday, Roger, about the best way to convince the board to do this is to have a beta test. I picked 5 employees in my company. I paid their DPC memberships for a year or until I was supposed to renew. And I told them there's only 2 things you have to do. You have to visit your DPC as often as possible, and you have to throw HIPAA away and report to me how well it's working. I told them I really didn't want details, but I needed enough details to understand that it does work. All 5 of them, it worked tremendously. So now I have the opportunity to go to the board and say, we're going to jump off this little cliff, but I think if we can control it correctly with the right vendors, the right stop loss coverages, and the right plan design, I think we can make this work. Convince the board to do it. January of 17 was my first month within the self-funded plan. About January 15th of that year, I found out we had a Hep C case. The first quote I got on the Hep C medication was $90,000. It's like, wow, that's gonna be fun to explain to the board. 15 days into the self-funded plan, we got a $90,000 bill coming. We knew there'd be bumps. I just didn't think it'd be 2 weeks into the plan. Jay, and I think maybe even you had something to do with shopping my Hep C medication. The initial $90,000 quote fell to $40,000 over the course of a 90-day period. I can handle that. The plan can handle that. We have the bank account. If we had to, we had stop loss coverage. So it was okay. After that bump, we really had no bumps like that for the next 3 years. Our health insurance fell by probably 50% from what it was in 2016, not counting what it would have been if we would have eaten the 10, 15, 20% cost of the premiums that would have happened. I got a lot more to say about DPCs, but maybe let's give everybody else a chance. And then if there's some DPC stuff coming back, I will touch more.
Taylor?
Okay, hi, I'm Taylor Pitlik. I'm representing Pitlik and Wick, which is an asphalt paving contractor in Eagle River, Wisconsin. We've been in business since 1952, so we're celebrating our 70th year, and I'm a 4th generation member of my family to work here. And our story is probably similar to many, and probably on this stage, is we came from a fully insured plan. And you know, it just, renewal time would come, and our brokers would come in, and we'd have the same spiel every time. It was, cost went up. We did absolutely everything we can, but there's nothing we can do. And that just always kind of got everyone at the company just kind of like a pit in your stomach of like, there's really nothing we can do to help, not only the company, but of course the members on your plan. I mean, just because our fully funded expense was going up, we did not feel like we were providing, better health care or anything like that. And we somehow went down a rabbit hole and found the Kempton group and saw that they aligned with really who we are as people, and kind of made the jump. That was back in 2018 for the 2019 year. And from there, we've really been committed. We kind of tell everyone that comes to our company, we're committed to providing health care instead of just health insurance. And although we switched in 2019, really the first 2 years that we switched, we weren't able to apply any of the free market principle, not any, but we weren't able to deep dive into the free market principles that a lot of you talk about here, being in Oklahoma, Texas. We're in Wisconsin, which is one of the states with the highest costs of health care, health insurance, excuse me. And so although we weren't able to, apply maybe going to Surgery Center of Oklahoma, it was an option, no one really wanted to be the first one, we still saw a reduction in our claims being self-insured. We didn't hit our estimated value, so we were able to save 25% and our claims kind of leveled off. And that kind of gave us, some talking points to our members on the plan of, hey, look how this changes. We were able to come to them and our premiums barely went up the first year. We had communication was a very big thing for us, and probably everyone can agree with that. We were the first employer in Wisconsin to go with the Kempton group. So when you come to your members and you're basically saying, hey, we're revolutionizing the healthcare industry, a lot of people, some people want to jump on board and other people are like, what are you doing? So we really had to work hard with communication about, it's not just about cost per se, it's also about quality. The breakthrough for us was the president of our company, his wife needed surgery. And she also happens to be my mother. And so she came and she said, I need this surgery. And I said, you are going to the Surgery Center of Oklahoma. And, she was for it. She knew we had been talking about it and how important it was. And we went down, I was able to be her travel companion, and so we took pictures, we wrote up a whole article to share on our company intranet of like how we got there, what we did, pictures of our hotel room, pictures at the surgery center, just everything that went through, and just how great of an experience it was. She, actually it was so great, she had to have another surgery just a couple weeks ago, and right away she didn't even want to go anywhere else. She just wanted to come down to Oklahoma. And that kind of got the ball rolling. We finally had the first person break the ice, and we've actually been able to have two more surgeries here in Oklahoma. And so now we really just, in our third and fourth year of going self-insured with the Kempton Group, things like that, we really start to feel like the pieces of the puzzle are coming together. We've also added a lot of partnerships to our plan. So we have a PPO network still with the Alliance, and that's a Wisconsin-based network. We're not really able to do the reference-based pricing due to some of the hospital systems in Wisconsin. There is a lot of balance billing and things like that so we've stuck with our PPO network so far. They're able to negotiate. They're committed to transparency and things like that. So we've found value in that partnership. Also, we just talked about, we moved to Southern Scripts as our PBM. That has allowed us to partner with other prescription services as well, Scripta, script sourcing, a lot of pieces. And then we also found value with, we have the FRM Plus and Visa Health, who I know are here. And they've really kind of been a missing link for us in Wisconsin to shop around. Right, not everyone's going to be able to hop on a plane and go to the Oklahoma Surgery Center Oklahoma. Ideally, that's what we'd encourage, but at the end of the day, you must be able to make the choice that's best for you. But what Visa Health has been able to do is they're our patient advocate, nurse navigation. And so to kind of talk about like what they've helped us with just recently is we had a member who needed ear surgery. And so they went through the patient care advocacy and they shopped around, and the prices in network through our PPO ranged from $1,700 to about $22,000. So that's all in network. So the member thinks, well, I'm going in network, that's what I'm supposed to do if I'm not going maybe the free market route. And that's just an eye-opening experience of just, wow, I thought I was doing the right thing. I'm going to the in-network hospital, but I could, the bills come out different. And we still have a high deductible health plan with an HSA. So there is, some issues with that is that the members will have to pay, and then they do have an out-of-pocket cost. So even though a lot of people, ideally we would like to get to the route where we can just waive the deductible first dollar benefit and things like that, the members still do have a little bit of the monetary incentivization that their choices do matter to them, not only just to the company. And ultimately, of the 1,700 to the 22,000, only one of them was a guaranteed price, and that was here in Oklahoma. So just having value in partnership, I guess that's kind of one of the things I really wanted to touch on, is like power in partnership. As we've grown as a company, as we've gone farther into the free market healthcare movement, we've really just had a lot of value added to our plan with all of the partnerships we've made. And if you're an employer thinking about making the jump, you don't have to have everything figured out right away. We kind of just take it year to year. As we learn new things, we try and implement it. Like I said, we're kind of some of the only employers in Wisconsin to really try and embrace the free market movement. So we come up with a lot of different things than you may experience in Oklahoma. But year to year, we just take it and we hope to spread the message and really just empower our members to have better health care. So.
Thank you, Taylor. You covered a lot of ground with your strategic partners, and it takes quite a bit to make all the plans successful. I'd encourage anybody that has questions on all of those partners to talk more with Taylor on that. Yep. Steve?
Great. So our story is a little bit different, and as Taylor had mentioned, I'm Steve Boyd. My wife and I started the company Southern Scripts. At that time, there was 4 employees, and so we had to be fully insured. Then we became 10, and then we became 20, and then we became 50. And remember, I'm out there pitching Southern Scripts services to self-insured employers, and guess who my PBM was? Optum, Yeah, and I can't see you, but I can feel how you felt. So, and so when we got to the stage of about 50 employees, I really started pushing our broker. I said, hey, I want to go self-funded. And he was like, no, can't do it. You're too small. It's too much risk. Well, I'd been all over the country learning about captives and level funded plans and all of these neat relationships like this. And I said, you know what? You're fired. And so we got rid of them. yeah. And I said, we're going to do it. So we developed a health committee, advisory committee, and we all have different privileges. And so we went to work, and we went out and said, well, we want to obviously be our PBM. Who should we partner with for a TPA? And we found our TPA, and then we found our stop loss, and we put that plan together with approximately probably about 60 employees at that time. The very first year, we saved $300,000 off of the premiums that we had. Now, the challenge is we're a growth company, and so now I sit before you, and we're just shy of 300 employees. So even though our costs have gone up because we have more employees and so forth, we know based on those earlier days, we're still saving money. Obviously, as a PBM, we've done incredible amount of work on managing the prescription claims because we're experts at that. And we've instilled our program called Variable Copay, and we give the patients the ability to get their drugs internationally. And we have patient assistance services for the employees that are more low income. We have all that in place. But I sit before you to tell you, we got work to do because I've learned a lot at this conference, and there's things that I'm hearing that we need to put into our health plan. And I just want to stress as I conclude to you all, that's the beauty of stepping away from being fully insured. You now have flexibility, and it's an evolution of change and opportunity because there's entrepreneurs like all of us out there wanting to help control our costs. It's all about finding them, determining if they're a good fit for your organization and where you're at so you can enhance your plan. And as I do conclude here, what our number one goal, we're going into our 4th year of self-funding, is we want to give back to the plan. We want to give back to the employees. So we're beginning to now take the proceeds of the savings and enrich the plan in the opposite direction of that high-funded health plan that we currently have in place as well. So very appreciative of the opportunity. I met many of you, and hopefully I saved you enough time where you can give your spill.
And not left me too much is the most important thing. Yeah. So I'm Derek Francis. I'm the CFO for Hospice of Wichita Falls. So 6 years ago, I was in public accounting, and unbeknownst to me, I was about to have this great opportunity to go work for the great organization that I do. And one of the first things I remember, I had the healthcare for my family, was getting that call from our HR department with the job offer, and I was so excited. And I asked about benefits, and I could hear this audible awkward silence on the other end. And, how much is it to carry me and my family? So I'd been paying about, I think about $460 a month, which I understand now, is great coverage. But I think back then it was over $1,000. And so it was, high deductible health plan. And so, we found other options for the rest of my family, and I took the job. But it's something that from day one that I was very passionate about. And so I'm going to spend a lot of my time talking similarly that Taylor and Steve did, kind of about what led up to that decision of making that change. And so one of the speakers yesterday said two things that stuck with me. And one was, when they asked the folks in the nursing home what's one thing you wish you could go back and change, would be to take more chances. And I definitely try to live my life like that and not be scared when you see a decision that you think is the correct one, not to be scared and to be brave. And the second one is that in the model that many of you are in and that we were in, is that the insurance companies are tied, with the traditional insurance brokers who are, tied with HR departments with a lot of these companies. And that was certainly the case with our company. And so as years went by, the renewals started out with small increases, single digits. And I always felt like, I wasn't intimately involved at first, but I always felt like we were buying a car from a sleazy used car lot. And the salesman would come in and he'd say, man, this is the first offer, you had a lot of high claims last year, and things aren't getting cheaper. So you're looking at an 18% increase. And we'd go, God, that's crazy. And then he'd come back and he'd say, guys, they've never done this before. But if you sign, this no shop clause, they're going to get you down to 10%. I mean, can you believe what a great deal they're going to offer you? And, meanwhile, then you kind of look and you say, well, how much are we paying these people? And you look and it doesn't look like that much. And it's like, well, geez, why are they so, excited about keeping us on this fully insured model? And undoubtedly, there were perverse incentives built in, to the fully insured model, to the point of so once I did become more involved with the healthcare benefit side of it, the last couple of renewal meetings, they get out their fancy books that are printed and bound and laminated in full color, and within the first couple of pages they'll have all the different healthcare models, right? With fully insured being over here and self-funding being all the way over here, with a lot of those things you mentioned, level funded, reference-based pricing, all the way to completely self-funded. And kind of as we would move down the page, they would explain all the reasons why those options would not work for us. We were too big, we were too small, not in this community, your employees are too sick, So fast forward to a couple of years ago, my financial statement auditor actually brought to my attention that there were some brokers in town that were talking about some alternatives and talking about some self-funding. And so that first year we talked with Kelly and David, financial partners, and it wasn't the right time. It was a little bit too late in the renewal year. But when we sat down with our broker the next time, I felt sent them very clear warning bells of, hey, this is not working. That year we had over a 20% increase. And with no additional benefit to our employees. They had a $6,000, $12,000 out of pocket, of which the plan paid not $1 other than their annual preventative visit. And so, still really high premiums for our employees. And so as we went through this process with them and stepping away from the traditional broker, it's never been about saving money for me. And I know that may sound strange coming from a CFO, but of course that's great if we can save the company some money. But for me, it's about having a healthcare plan that I'm not embarrassed when we're trying to recruit and retrain talent to hand them and say, this is what we expect you to pay your share of, and these are the benefits. And I feel very proud of what we've been able to put together in just a very short time. So we're in our 6th month. I will tell you that it's not easy. And one of the analogies that Kelly Fristow uses is, it's like if you were to do all your grocery shopping at 7-Eleven, right? as if you're, if you're fully insured. It's easy, but it's expensive and the quality sucks. Whereas this is definitely more work. You're gonna have to work with your TPA and with your employees and with the providers around town. But I feel like it's gonna be front-loaded work. We're the first folks in our town really to try this. And so as providers are becoming more familiar with it, you only have to do it once with each provider. And then the next time they're like, oh, I know what this is. And so that's been our experience so far, has been largely positive, but exciting. And I'm definitely an expert by no means, but we were just happened to be put in the position to where we had to do something different. And when our stop loss quote came back and we saw that it was multiples of 6 figures lower than our renewal, we really didn't have a decision to make from a money standpoint. It was just, would we be able to put together a robust plan offering in that short amount of time? And working with some great people, we were able to make that happen.
And you're also heavily utilizing direct primary care into your plan and getting good employee feedback.
Yeah, everything kind of came together all at once. Around the same time we were talking about going self-funded late last year, 2 physicians, a husband and wife, were leaving the big hospital physicians group to start their own direct primary care clinic. And they're not the first in town. There's one other who really pioneered it and showed them that it worked and that there was a need for it in our community. And so they've stepped out. They opened their clinic January 1st. And I think I think we have about 215, 220 employees. I think over 70 utilize the direct primary care. So very, very good participation.
That's great. Any other comments? Drew, you've always got something else to say.
Oh, I have too much to say based on what that clock's telling me.
Any questions from the audience?
This question is for Southern Scripts. Earlier in the breakout session, you mentioned that your revenue model is a simple transaction fee. And you kind of compared CVS and Therapedia and Express Scripts, et cetera, in terms of a lot of the markups they had. So, with all the savings you're offering, could you just expand on what you mean by the processing fee or the transaction fee and how Southern Scripts makes its money? Because, I'm sure you're not just passing through everything and just, that would be a bad business if 100% of the savings constantly are just being passed on to the customers or the employers.
Sure, be happy to. So our model is one source of revenue. And so let's say a plan processes 10,000 prescriptions that are paid claims, not reversals and such. We attach a fee to that claim, and that fee typically is around $8. And so in that particular case, if there's 10,000 prescriptions, we would make $80,000 over the course of 12 months. Now, that was our original model, and then as times kind of changed and the marketplace changed, and one of the BUCAs, the Blues and the United, the Cignas and the Aetna started lowering their upfront fees, we did have to do some things differently. And so, for example, with the Kempton group, we put a per employee per month arrangement together. And so we step away from that admin fee arrangement and we work with them to find a sweet spot for that matches their admin fees on the front end of the TPA. And we do that with a variety of other arrangements across the country. But the point of that is that it's still transparent, it's still very specific, and you know exactly what you're being charged from our arrangement. So.
Hi, Jesus with Surgical Serpa. And one of the things, especially for mid-sized companies, one of the things that we see with fully insured, but it may happen with self-insured, is that what happens with those members that cannot afford the premium, or even they cannot afford to put their family members, the dependents, on the premium, but they have a healthcare need. How do you solve that problem? Thank you.
In our case, our premiums were dramatically reduced when we were able to go self-funded. So that was one of the big catalysts for us wanting to change. We always struggle with, trying to put ourselves in the shoes of some of the lower income folks in our organization and that have families. So we want to keep those premiums as reasonable as we can, while also, you want the employee to have a little bit of skin in the game with the plan as well, and incentivize them to use it to the best, most sensible way that they can. But in our case, our premiums, we were able to lower them substantially from a fully insured model.
I think it's the same comment. If you get the plan too rich, and I hate to be a black and white capitalist up here, but for a little bit I might be. Our plan got so good that employees were recruiting folks out in the community that they knew were sick. And they were coming to our shop and accepting lower hourly wages because our plan was so good. So there's kind of a happy balance. You need to recruit the right people, but you don't want to recruit somebody that's going to cost a health plan a lot of money when they're coming to your shop knowing that if they follow the bouncing ball, they end up at SCO and they get a brand new hip and a brand new knee and a brand new shoulder. And, all I had to do was work there for 6 months and I got hardware and all my body parts. So you got to be careful. You can't, when we started, we had a lot of pent-up demand that I had no idea existed within my employees. Aetna had told a lot of people no, and that first 6 months of the self-funding plan, SCO got a lot of business. They got a lot of knees, they got a lot of elbows, they got a lot, and it's like, why didn't you guys get this done when we were fully insured? Well, Aetna told us no. Why didn't you tell me? Well, we didn't know we should. So when you start, there might be some pent-up demand because what do you call it, bukas, they might turn down some stuff that as an employer you don't know about. And as soon as you flip the switch and all of a sudden it's a great sweet plan, there's some pent-up demand out there.
Drew, you are a self-funded benefit plan, as long as Taylor and Derek. As the HRs and the employers of your company, how do you talk to the employees about your self-funded benefit plan so that they engage and kind of engage into what we're trying to do? So how do you educate and talk with your employees about your self-funded benefit plan?
So there's 3 pieces of the plan. You have to have the appropriate plan design. You have to have education, education, education. And then you have to have them actually follow the plan once they get to the point where it's needed. And sometimes when you get to the point it's needed, you kind of forget all those conferences and sessions and HR talks you've been through, and 3 o'clock in the afternoon, you go to the ER because you have a stomach ache. And that makes me really unpleasant. So education of the employees, getting as many of those employees directed to a DPC as we can, so when they do have that stomach ache, they're texting their doctor that's going to help them. And the stick. Since 2017, financially, there's only one piece that's gone up in my plan for the employee contribution. The premiums, the contributions have stayed exactly the same from 2017. The only piece that's gone up are co-pays outside of Kempton Free. As KPP grows more and more providers, my employees have more opportunities for zero copay products and services. They can go outside of that. If they do, their copays are going up every year. I have a stick. You can use whoever you want. But if you don't follow the bouncing ball from the DPC to Kempton Free to SCO or to Oklahoma ER or to McBride, all the good players within our network, it's not a network, it's just a whole bunch of folks wanting to do it the right way. You can go other places, but if you want the Cadillac or you think it's a Cadillac and it's probably not, you can pay for it. So education and giving them a stick where, okay, if you don't learn this, it's gonna cost you money, is the best opportunity we have to drive them in the right direction.
Yeah, where we are as well with communication, we found that when you focus on the members specifically, less about the company, the cost savings to the companies and and things like that, when you communicate directly to the member and what it means to them, we found a lot of value in that. I think when we first switched, that was maybe something we did, maybe not the best. We did kind of talk about the overall broad picture cost savings, to the company, which of course it does trickle down to premiums and things like that. We know that, but it's been a much more effective communication strategy to focus on just the members themselves and how it affects them. So.
Todd, we have one more question, real quick. For Drew, with getting back onto that, about how many percentage of the members do you have that actually utilize the direct primary care?
I believe we have about 80 people out of the 140 employees that are on the plan.
Do you charge them more for the DPC? Or
Oh, no, ma'am. So I'm glad you asked. That was the best question of the day. DPCs pull out $100 a piece because y'all are going to owe me some money. So anybody that chooses to use a DPC, I pay 70. So in Oklahoma City, the market's about $75 a month. We pay their membership fee. Not only do we pay their membership fee, so we're also, our DPCs can also produce pharmacy. So any drug that we can get from our DPC, I pay up to $100 a month in what they can get directly from their DPC, whether it be drugs, whether it be they have DLO contracts, so we can get labs for $18. So anything, and Jay hates me. Jay and I may disagree a little bit on this. I don't care if my DPC reports that he gave 3 different drugs in a lab and it cost me $72. Because what it might have done is it might have saved me an 1,800 GERD pill. And it has saved me many $1,800 specialty medications across the board because the DPC works with them. They change their diet. They change, well, my DPC tries to change my diet. But he gets me the right drugs. And most of the drugs are 3 cents a piece to 8 cents a piece coming out of his dispensary.
how about for their family members?
If their dependent is on the insurance plan, yes, same deal. I think it's, in our market, it's $75, $85 for an adult, and it's $35 for folks under 22, 23. They have different fee schedules. But I want them healthy. So spending that $100 a month, $120 a month, that's a no-brainer. My DPC, we do health fairs. All the DPCs come into the office once a year. We do flu shots. My DPC comes to the office, gives everybody flu shots, including dependents. He gets to know them, they get to know him, and it's open to all the DPCs. They're welcome in my shop anytime.
Well said, Drew. Thank you, employers, for sharing your story. We've got to conclude. Thank you.